Good afternoon. I hope everybody can hear me online and in person. Just checking with June that is the case. Yes, it is. Excellent. My name is Bianca Prachna. I'm a professor of health communication here at La Trobe. Pleasure today to host Dr. Pallavi Nair from Imperial College in London.
Please speak up.
Speak up in the UK. All right, I'm just quietly mumbling while more people come into the room virtually and in person. We have 2:01, so I will officially open proceedings. So I will begin by acknowledging the traditional owners of the lands on which we meet. For us, that is the Wurundjeri Woi-Wurrung people of the Kulin Nation. I pay my respects to elders past and present, and extend that to any Aboriginal and Torres Strait Islander person who's joining us today. We recognize their enduring connection to land, waters, and culture, and acknowledge that sovereignty was never ceded. And thank them for caring for country for tens of thousands of years. So today's seminar is hosted by the Care Economy Research Institute, or CERI, in partnership with the Mindcare Collective. Just a brief overview of the Care Economy Research Institute. It was established in 2023 by La Trobe University in response to the growing challenges facing Australia's care sectors, and from a strong conviction that researchers and industry partners can work together to drive meaningful change. CERI is Australia's first institute dedicated to research across all aspects of the care economy. Mindcare Collective, which Joe and I lead, is a program of interconnected projects at La Trobe University focused on dementia prevention. No, go away, Siri. I can't connect to anything. So Mindcare Collective is a program of interconnected projects led by La Trobe University focused on dementia prevention and culturally safe, accessible support for culturally and linguistically diverse communities. And we work alongside multicultural communities and partners across Australia to improve access to brain health education, reduce dementia risk, and support more equitable pathways to information services and support. Our speaker today is Dr. Pallavi Nair. Pallavi is a DEMCON Fellow with the Applied Research Collaboration Northwest London, the NIHR ARC, and is based at Imperial College London within the Department of Primary Care and Public Health. Trained as an occupational therapist specializing in neurological conditions, her current postdoctoral work focuses on capacity building for community health workers and the translation of community-driven, culturally informed approaches into dementia care practice. She leads and co-designs initiatives that enable proactive dementia outreach, relational care, and sustained support across dementia care pathways, particularly within multi-ethnic and underserved populations. Today, Dr. Nair is going to speak on translating research into everyday support, building dementia-capable communities. Before I invite Pallavi to speak, just a quick bit of housekeeping. It's a hybrid format, so people are online and in person. If you are online, please ensure your microphone is muted. You're welcome to add questions in the Q&A function or via the chat. We will address all those questions during the Q&A session at the end. If you want to ask your questions verbally, just use your raise hand function and we'll invite you to unmute. You can directly ask Pallavi your question. If you're in person, the room has a built-in audio system. So during your Q&A, just raise your hand and speak very clearly, unlike me, so your online audience can hear your question. The session is being recorded, and if you're participating, you may appear in the recording, and if you prefer not to be visible, keep your camera off. You're on Zoom, and if you're in the room, the camera will primarily be focused on the main speaker. Pallavi is going to talk to us for 35-40 minutes, and then we'll have some Q&A. So over to you. Thanks.
Okay, thank you so much, Professor Bianca, for the generous introduction. And I feel really privileged to be here on this land. And this was only possible because of the La Trobe University, the Care Economy Research Institute, then Mind Collectives. Thank you so much for having me here. So I am having this pleasure of actually walking you through my journey of building dementia capability in the community. To start with, a bit about me. I come from India and I have done my bachelor's and master's in occupational therapy. When I was making this slide and I saw 2006, I realized it's been 2 decades. Wow, we are in 2026. And yes, having done my bachelor's and master's, I was too intrigued to work in the field of research. And back in 2014, call me a visionary who did work in telerehabilitation in India, which was quite a boom after the pandemic happened. So yes, that went well. And during this time, I got the opportunity to pursue my PhD in neurology at the All India Institute, where I had this brilliant work to be done in longitudinal aging study and do the early brain biomarkers. So I made my transition from the clinicals to public health. And during this time, transitions are inevitable. There's nothing linear as a PhD that happens to you or in your life. We had moved to the UK, where I worked remotely as a consultant for different organizations. And then finally got my first postdoc fellowship, and that also at Imperial College, where I pursue health service research and do a lot of work with primary care team, the network, GPs, and their connected roles, which I'll talk in more detail. I am one of the 72 dementia fellows all across the UK. So there's this beautiful funding that came up to Professor Ruth Butler, and she had taken different universities. She funded them to develop capacity of dementia researchers. So I represent Northwest London that way of the arc. So I prefer to start with this iceberg metaphor of what we see is what we act on. And that is what the healthcare system is doing with dementia care. It's on that crisis mode where people have late diagnosis, they reach the system late, there's only treatment based on their present urgent situation, and overall, the care is reactive. What we don't see lies beneath the iceberg layer are the human realities. Isolation, fear, navigating the system alone or with their family members, and also knowing the unknowns, the uncertainties. And this is the area that most of my work focuses on. So to imagine this area to be worked on, we reimagine dementia care. We see it more into the community-based world where there is a transition, a paradigm shift from hospital-centric to community-embedded. And that's what is one of the potential solutions. Primary care being the gatekeepers of our healthcare system, similar to what we see in Australia, similar to what is there in the UK, is that there was a study done which has very compelling evidence saying that 40% of the dementia cost reduces when you put in the primary care through a task shift or task shared approach. But how do we operationalize that in real community? It's not that transparent, it's not that translational. But we asked that, and during our review paper, we came across what are the challenges at system level, at human reality level, and where are the gaps that can be tackled with. You can go back and see that paper later. But this is what we did. The solution was simple, yet very profound. Rather than developing new parallel silo services, we reimagined the already existing care pathway. A care model, community health and well-being workers, I would refer them to as CHWWs for short. So they are reverse innovation from Brazil. They have been there in Brazil for the last 20 years and capture 80% of their population. So this model has principle on being comprehensive. When they reach a household, they see everyone from the child to an older adult. They are hyperlocal. They live in the same community they serve. and they have only 150 households to see every month. Irrespective of the need, they'll do a door knock and ask, "How are you?" They are well integrated within the primary care system. They have access to data points, data sets at the GP practices, and they're very universal in their approach. So what they do is community engagements, they catch up, do signposting or handholding for people. What we felt is that they were right at the intersection of primary care and community, where we wanted the care to be more. We had to do their capacity building. Because they are multi-ethnic in their own composition, they represent the cultural fabric of their community. It wasn't too much of a task for us, but we wanted to make it more culturally responsive across the care pathway, from prevention until the end of life care. Because we saw the potential when they do a door knock, they would have that capacity of identifying some early signs. Isn't that what we are missing? Some of the early subtle changes that happens in everyday living. Because dementia is more than clinical diagnosis. We are focused more on the hospitals, but it doesn't begin at the hospital or the MRI setup. It begins at the kitchen countertop, a missed appointment, everything in and around activities of daily living. So that's where we found them as a potential dementia-capable workforce. What we did is that we started listening to people. We embedded community participatory approaches in our research study. We met 72 stakeholders from public partners, even residents 45 years and above in the community, to the other healthcare settings, GP practices, GP receptionists, the admin teams, and then the dementia specialists. In the UK, we have a lot of connector roles like dementia navigator, dementia advocates, dementia link workers. We ended up having them in the same group. And we asked them, what are the unmet needs that you face in your practice? Because you are the specialist. We want to make community workers capable enough to know that they have to reach out to you to connect that dot. We had focus groups, interviews, process mapping. We asked community workers, how do they help someone who's elderly, having those memory issues now? And then after training, we can do a post-process mapping on how they are connecting with other dots. Our data analysis showed that there was a lot of opportunity for integration. For example, a dementia navigator or the admiral nurse saying, I'm a specialist. I deal with the carers. But if a person lives alone, I cannot support them. And there are 40% of this population they're talking about who needs the actual kind of support. And they said, we can help them with the services. We can tell them what there is. But you, maybe a Chewy, a community worker, can go back and check in at a household level, whether they are going for those services or maybe take them as hand-holding to those services. That was very meaningful and valuable because they visit them every month. Rather than spending the time at home, they might take them out for the appointment. That way, it felt more culturally relevant to them because they have the same ethnic background. If not, if someone is speaking some different language, they ask one of their colleagues to accompany them on the same day. So there's a lot of flexibility they do within their own settings. Again, there was more of co-designing that we did for our training. There was a project steering group, people with dementia, their carers, so on, some of the specialists. And we did regular meeting over a period of time to understand what exactly we can have in our module, the toolkit, and also what came out brilliantly was that we co-facilitated it, the training itself. Rather than one person telling about dementia, we had these admiral nurses from Westminster and from Hammersmith and Fulham to come and speak to them because they were the faces they might see in the future when they have to connect someone. So it was also relationship building with the practices. We've got some videos back from Brazil. There we had their ideas on how they support and what can be done. Our module was ready. It is a one-day program. We did a post and a pre-evaluation. So this is what we've built. We've built our ComproAct module training. That is one-day training, 5 hours. We do not want to overwhelm the Chewies. We understand they have their universal role. So we inform them about understanding dementia through cultural lens. We inform them about some unconscious biasness that we have in our own culture. There were some beautiful videos and narratives that came across. With all this focus group discussions and some activities, some real case discussions, we were able to help them navigate the pathways, what conversations, how to initiate that, foster, understand whether the person is ready to know what is dementia and know what is in their language. It may be just memory loss because dementia word cannot be translated in every language. And I have experts here. So yes, so we had multidisciplinary networking at the same time, they knowing whom to connect, and the practical toolkit that is out there. This is how it looks. It's got resources, it's got services that they can connect to. And we made the resources according to their role. So it was something like you want to tell about awareness, we've got links, multilingual. The mind care is there as a link. And then we talked about if you're concerned about a resident, what you can do. Maybe because next month you'll go in again, you can have a check-in, you can just see, open that conversation if they're ready. Then preparing for a timely diagnosis, because that's what a real lag is. We might just get an appointment with the GP, but what happens during that time until they have their memory cleared? 3 to 4 weeks, a person is under such stress and uncertainty on what will happen. So that way they can give the emotional support even after getting the diagnosis. So that time where people feel most aloof on what to do, a person checking in at home, going through the pamphlets and sharing, this might resonate well, I'm happy to take you, is what felt more meaningful and valuable to us. With that, we have a lot of support for carers and families where they can apply, what services are there, what concessions in the housing tax and other things they can avail, and communication tips. So for now, we have trained 35 CHWWs across 3 boroughs in Westminster, Hammersmith, Fulham, and Harrow in the UK. They're very multi-ethnic and very diverse. What we have understood is that initial pre and post evaluation has shown us very valuable results in the sense increase in knowledge, which was significant, and also increase in confidence, which really mattered when some of them said, I've got the vocabulary now, which I did not have, how to speak to someone. Or maybe the training made me reflect on my own assumptions about my culture. But I feel now it just doesn't mean that we move countries, the culture gets adapted. We get adapted to what is there in the new country. For next steps, we have our 1-year evaluation that is ongoing, and we've made sure that PPI was heard throughout the process. So from designing the idea to ethics to having the topic guide evaluated by them and the evaluation process as well. So they come up with such brilliant insights, something that is more realistic, relevant, and might take it to next level on people accepting it. So from there, the ComproAct, what I have earned is a lot more. We started with this, but what we felt was primary care is, again, very under-resourced, underfunded, but they have the real potential to make a difference for dementia care. So that way, I lead one of the special interest group for our DEMCOM community. We've got 12 brilliant DEMCOM fellows all across the UK, and we are writing up our paper on integrated care and sharing our different primary care studies, the pilots that we've been engaged with, to see if NHS would like to incorporate something. Because for now, the NHS is restructuring, and the main aim for the new Department of Health and Social Care is 3 major paradigm shifts. So one is from hospital to community, treatment to prevention, and analog to digital. And that's how the big shift is going to come. And they want to do it through neighborhood model. So we went a step ahead and we made our neighborhood team. So this is another very fantastic model, Octopus, that is being running in Westminster. It's a community of work where the director, Dr. Sol Kaufman, he is a GP again, but he's the director for primary care networks. And he felt that there's some kind of disconnect. And we need to get the connector roles in at one place. So it's a networking that we all go every 2 months. And there'll be different roles from social care, primary care, community, voluntary sector. The colors are different for different professions. So red is for local authority, which may have navigators, advisors, champions. Blue is for academia and policymakers. Yellow is for voluntary sectors like community workers, social prescribers. And green is for healthcare, somewhere from navigators, nurses, community matrons to GPs, and so on. To that, we added our public partners because we've realized that we need to make it more relevant from the start, and we've had them. Together, we work across for, it's voluntary. So we are working across together to make sure we come up with some solutions in the community. For example, awareness. Rather than doing alone, because everybody's doing at some or the other level, so we want to do it together. Then there was another seed fund that we were engaged with. This is on multimodal wearable technology. We thought there's a potential to identify the early subtle changes that happen in everyday living. And for that, we use different kinds of hearable. This was co-designed with 52 stakeholders, where we asked for service users, people with dementia, mild cognitive impairment, residents 45 years, to service providers like geriatricians, GPs, rehab professionals, coming in together and telling us what works, what won't work if we integrate this into the pathway. Again, very interesting themes that were emerged. Positive side, there's definitely continuity of care. They felt we might not fall into those cracks for 6 to 12 months where we have no follow up. There'll be someone monitoring us remotely. But on the downside, there were challenges on what if I don't wear it? What if I lose it? Or what will be those trigger data points that will tell me that I need to visit the GP now? So those kind of implementation side is what we were exploring. And this was just a stakeholder study to get the PPIs to understand whether there's acceptance or feasibility for doing something like this. Because digital era is something we cannot escape. We need to make it as an asset for dementia care and make sure we have it embedded within the pathways. There was this Dementia Action Week last year, a wonderful opportunity to connect with the community, and we did it for 5 days because it was based on the 5-finger model, on working on different aspects from your cardiovascular to social engagement, diet, physical activity, and mental stimulation. So we went ahead and said we need to redefine prevention. Because for now, it is all about these people are at risk or they are aging, so we need to have that prevention there. But people who are already diagnosed are at 3.5 times percent higher risk of developing comorbidity, having those 10 medications a day. We need to tell them what are the lifestyle modifications that would work. So we invited everyone who wanted to come. We did the engagement one day. We did mental simulation with wearable technology in a care home to see how they feel about it. There was chair-based yoga, nutrition the other day, and regular health check-in. So this, I did it with other Temcom fellows with me, 3 of us doing different days here and there. This is another seed funding that we got because we had Octopus Group, and we are doing community. So it is tea gathering, unity over tea gathering. Because tea has this very special place in South Asian communities. And so we ended up meeting the faith leaders and having that culturally resonant kind of a message on what we need to say should be right to them, because we are doing these engagements at the cultural hubs, temples, gurudwaras, and mosques. So we want the language to be right. And this is what we don't do it alone. We team of 10, 11 people go together and see, we share our insights because we've got people with dementia in the room. So they share their insight, they motivate the people, and the message would be, it's time to see your GP and timely diagnosis matter. So there's some kind of public messaging that we are working on, and the sooner we should be able to popularize it. My other intern project, because I've been working under the water surface on human realities, so it was Photo Voice that beautifully captures the narratives of someone who wants to tell their story. Rather than having 1 to 2 hours of interview, what we did, we gave them cameras, which they were gifted later, but we gave them cameras to share their story of navigating the care system or what gives them hope and so on. And they came up with this beautiful images. One is shown here that says, holding on to hope. Even the path is uncertain, there's hope that comes from my faith. And this was a carer who shared this story for her father who's having dementia. And that's what you feel, that we can empower the carers, people with dementia, and so on. We had the diet because our group did not have early onset. They were somewhere in the middle transition, and the carers helped them, took the photographs. But eventually, it's all about empowering people and giving them just a scale of seeing how everyday activity is. So this came out beautifully. So eventually, just coming down to what I've learned through is absolutely going down to the level, talking to people and understanding what's really needed. What works is a bottom-up approach. You co-design it, you learn what they need, and that is where acceptance comes more easy. Collaborations, absolutely. You want to go fast, you go alone. If you want to go far, you go it with a group. And this is what we feel we can always have that common interest that we can work together on. And we've come up with this, I feel, if we want to translate it, it's all about implementation. That is the real innovation and not just any device or any new technology. So doing it in the existing pathways, capacity building of frontline workers like we did for community workers, there are a number of connected roles, even the shopkeepers, somewhere what we have back in the UK is Asda, Tesco's, the shopping malls like here, you've got Coles, so supermarkets. So people need to know more. So capacity building of them, sustaining would be better economically and more, there are more forces to support them. Community-led is what the local people are the ones that have the potential to get to the place. And they are the driving ongoing support. Faith leaders and community leaders, this message coming from me or coming from the faith leader, dementia is a medical condition, full stop. That would reflect more in their regular Friday meetings or Sunday meetings. Just a small message, if somebody is struggling with memory, confusion, personality changes, reach out to your doctor, is what we are trying to find, where we can get in. Culturally sensitive co-creations and delivery is where we support them. And the vision we have for future is no one sees dementia alone. Or they don't have to face it alone at least. So it's only when we embed the community, we might have that work. So I leave you with this image because this is what I feel. If you ask me what I'm doing, I would say I'm a bridge builder and I'm connecting the dots, and this is in the community and through human connection. So that's what makes it very special. So we are moving the care and we are envisioning the care from being more reactive to proactive, hospital-centric to community-anchored. and transactional, a one-off kind of a treatment, to more of relational builds. So relational care is what we are looking at. That's my team. I've got Dr. Matthew Harris. He is the one who went to Brazil. He's a GP. He was there for 4 years. He thought the CHWW model was just so ideal for reverse innovation, and that should be something for underserved communities and people from multi-ethnic background. So it's his brainchild. Dr. Connie is the one who's the clinical lead and makes sure that this workforce is getting the right kind of training and right kind of place. Dr. Benedict is the GP specialist as well as digital health. So he gives me supervision with that. Pete, Michelle, they've been brilliant public partners. I couldn't have done it without them. We've got the Chewies who are making the right kind of difference. So my special thanks to all of them, my collaborators, for sharing the valuable insights and for this opportunity today. My logos are increasing now at the end, and yes, they will keep growing. So thank you so much. I'm happy to take any questions. That would be all. I'll stop sharing. I know what June asked me to do, but I'm happy for you to do that. Yes. Thank you so much. Yes. That's me. Okay. Okay. Absolutely. If there's any question in the room, I'm more than happy to take that, and then we take anything. You have a question? Oh, I got one.
Wait, Irene's got a question, and then we'll go to
that. Absolutely. Well done. I mean, it's a great work that you've done, and obviously, it's great that you engage with the community, maybe right from the beginning. I just have questions about the funding model. I think, particularly, I guess, when we try to roll out, scale up, whatever, I guess, from the government's perspective, it's all about money.
Yes.
So have you done out the business case model or, some economic evaluation, at least, I guess, to show how much does it cost, to do this, and what do the government will get out of it in this?
Absolutely. Thank you so much.
It sounded cold, but in my experience,
no, that's the reality.
I'm sure the governments everywhere will be the same.
Yes.
Australia.
To tell everybody just a bit of a background, this model took 13 years of traction in the NHS by my supervisor, Matthew Harris, to get it rolling down.
Yeah.
It's been 5 years. They've done some economic evaluation that says it only takes 1.2% of the NHS budget back in 2023-24. So 2.2 billion was what it was evaluated then. I'm sure there's a new upcoming evaluation for it, but definitely cost effective in the sense the latest report that was published by Connie says that it has increased 80% of cervical screening, so it's being proactive. Then NHS check and reduced 7% of the GP appointments. So they're trying to make that difference, but any model takes time. This was the evaluation done for 4 CHWWs only, and now there are 250 all across the UK. So scaling is happening. And also to answer the question on funding is what everybody believes in this model. So the primary care settings are putting in the funds. The National Institute for Primary Care, the National Association of Primary Care is putting in the money to embed them because they feel they are more of the eyes and ears of GP practices. They reach out to the residents who haven't been to the GP practice for 1 or 2 years. And those are the ones who might reach late and those crisis management mode happens. So being more proactive, reaching to the, we say hard to reach, but it's the system failure that you're not able to reach them. But they were able to do door knock. And this door knock also, there was an evidence that said minimum 4 door knocks. So 4 months of door knocking, going to the house needs to be in place to build that relationship. So it has taken time, but it's there.
So how much does it cost really? I mean, it's great that you can obviously make some connection in terms of the impact. But if I guess, if say like, if we want to replicate that in here, what kind of funding are we talking about? Is it like, per program in one local area, say, surfacing up to, like 100 people, you need to spend like, one FTE, someone costs like 50,000 or whatever,
So I need to have my number correct, but I'll get you in touch with my supervisor who have a bigger picture of it. But they have somewhere around their salary, say 25 to 35,000. One FTA, and they see 120 to 150 households every month. So that way, 4 of them, and so on. They now see 20,000 households all across the UK, from Cornwall to Findlay, London, Surrey, Kent. They've expanded. Scaling is absolutely something which is there. But they were also mentioned in the 10-year plan by NHS, saying this is a very promising neighborhood model. So it seems, because they're universal, rather than 10 people going home, there's just one-stop solution. But we'll make them capable. They'll connect you to the specialist. That's how the vision is. Yes, please.
I like the model very much. Is there a risk, however, in the person living in the microenvironment where they potentially, like, if it was my neighbor, I wouldn't necessarily want them to know about my ill health?
So confidentiality and privacy is top priority. There's nothing that is disclosed until and unless the person needs someone in their own, wants to speak to someone in their own language. And once the consent is there, they go back to their colleague and ask, would you like to accompany me for one of the visits? And then they go together. So absolutely privacy. No one knows what happens in one household to the other. Yes.
There's a question online from Belinda Curtis, who asks, what were the challenges you faced and how did you overcome them?
Oh, thank you so much for asking that, Belinda. Challenges, absolutely. Getting into primary care wasn't easy. Never have been. What I've heard from other seniors. But because my entry was through the GPs, and all my supervisor, if you saw, were all GP practices. They were in that setup. So my transition to GP practice was relatively easy. But building those connections took a lot of time. Building that relationship with the GP receptionist to somewhere who's a dementia advisor. It takes time, absolutely, and consistency. I would say one tip, if you ever go to a community setting, like say South Asian community, have someone who's been to that community before. So for me, it was the CHW, because they were a trusted figure. They knew them, and then they introduced me. So that way, it just streamlines the process. Otherwise, it takes time. Thank you.
So any other questions?
Just a quick one. So the having kind of been in both the UK and Australia, there's a lot of kind of shared challenges in terms of the kind of fragmentation of the kind of healthcare system. And I was just kind of wondering about how the interactions between the community healthcare workers is affected by the sort of service provision challenges that are more kind of on the NHS side of things. So say, for instance, you see somebody doing a door knock, you're presumably coming into the home if you're a Chewy, right? Mm-hmm. Yeah. So you have that opportunity to actually see how the person is kind of coping in their environment, which is obviously a really important part of dementia, right? Like actually seeing people in their environment. So if the Chewy sees that the person is struggling and they are actually needing, something like a home assessment from an OT or something along those lines, right? How does that kind of interact with the existing kind of service provision issues in the UK?
Yes, absolutely. Thank you for that question. To give more clarity about their working with the bigger teams, wider teams, is that they are appointed by the GP practice. So they get access of the system one, where they can enter their notes, they can tell the GP about any red flags, so on. And the same time, they can connect to social prescriber. So in the system one, they can flag and say this person needs help for social prescribing, or maybe say an OT through a GP that this person needs a home assessment. Because they've got this integrated kind of a setting within the primary care, they are able to communicate with other professionals. But it was just that when we did our co-design, they said they haven't interacted much with the dementia specialist, and there are a lot of different roles that are there, and how should they navigate that? So that is what we made sure we had all of them in the same room and say, like, what works, what doesn't work.
So is part of the training that the CHUI receives about those referral pathways? That kind of like, to me, it seems like CHUI has like quite an important sort of no wrong door kind of approach. If they have that understanding of when they need to see a dementia specialist, when they need to see like a admiral nurse and all that kind of stuff.
Absolutely. So what we did is that we did teach them in one of the sessions on navigating the pathways and having that conversation. So we informed them what all services are there and how the process goes. In the early stage, maybe you can signpost them or inform them about the Age UK, Alzheimer's Society, give them the numbers. It's their part it's embedded in the toolkit to have those emergency numbers they can contact back to. But then again, in practice, because it was co-facilitated and they could meet those professionals, it felt very easy for them later during this evaluation phase that we are having. They said it was easy for me to contact the community matron because I had her number, I had her details, and I could just email and she came back to me. Now we are working together with one of the person living with dementia alone. So it felt as if, they were able to identify, but if they are not, they reach out to dementia advisors and advocates they already met during the training, and they ask them what can be done, or maybe you can help them go ahead.
So it's the prior knowledge that's actually really important.
Yes.
Okay.
But
in Australia, there's a lot of issues with regards to the lack of pathways.
Yes. But it's just that we are reiterating, and we are also understanding where further they can connect services to or be part of that. Another beautiful thing was for the memory clinics. We felt that 2 to 3 gaps, maybe they can check in before. The admiral nurse said it would be wonderful if they can sit in at home and tell the person what happens at the memory clinic. Rather than a surprise in the morning saying you'll have to stay for 2 hours, you'll have 1 hour this, the doctor will meet, then you meet the nurse, the whole process, they'll be more prepared. So we can work on that preparedness, we can work on that initial kind of opening that dialogue about it. So yes, they've got this diverse potential. We feel like they get their active listening training, so they've already got certain things in place. We wanted to tap in and make them more like a dementia-capable workforce.
Thank you.
Welcome.
So I've got a question, which is, this model works very well as a place-based approach and a geographically specific one. This is slightly unfair. If we were to take the lessons from the kind of geographic specificity of the UK and Westminster and apply it in a place like Australia, what lessons should we be taking? And like in Brazil, is it also as place-based?
Yes, absolutely. So we haven't done much on the principles. It's again home-based, it's check-in monthly, they're comprehensive, they're universal. What happened in UK, because we had to adapt with the culture, with the place, so they get a lot of training on understanding different conditions and how they can help connect the dots. So I would say it's very much hyper-local. I don't know how that works because I was having this talk on primary care is not that hyper-local. But then again, having some kind of catchment areas on here the CHUI would work, and they will report to this primary care setting. That way you can have that continuity of care is the major takeaway. There needs to be just streamlined channel. Otherwise, the principles, CHUI principles remain the same. Should be transferable to a setup like Australia.
The other question I've got is about the capabilities we're expecting of this staff, right?
Yeah.
So you've talked about the 5 hours of training they get to be dementia specialist or dementia capable. Sorry, not specialist, but capable. But what's the overall training that they get?
Yes.
And are we asking too much?
So I would just refer back to the supervisors who've got more knowledge on the comprehensive one. But what I have known is that their training just keeps going. So they've got refresher training every month on maybe how to measure blood pressure. So they know how to measure blood pressure. And then maybe how to enter things in system one. The next month would be how to do active listening or maybe cancer screening, being part of that. So there's a refresher training happening every time. But once they join, I believe there's a week-long training that they go through. And there are different modules that are there that they have to pursue. There'll be in-person and some hands-on training that they get. But then again, if this has to be in more detail, then Connie and Matt would be the right people to get back to.
Right. So they're technically health navigators plus more dementia capable.
Yes. So I would say they're just universal in the approach. Navigators will just tell you how to go, what to do. They can sit in, they can give you that emotional support. They are the residents of the same place. They look familiar. They are very much, you interact with them in the same park, supermarket. So they live in the same estate building like the residents, and then they are given that 120 households. So if there's someone who wears a badge and comes to me, I'll be cautious of what I'm speaking to them and how much. But if there's someone who becomes your friend during this, you build up this relation, they might open up a little extra to you. And then it's more than navigator. And dementia capable, the same way they have more knowledge of preventative measures. So cardiovascular, they know how to do BP measure. So they're being that universal kind of a workforce that was adapted in the UK. So they're making it as per the need that is there. So yeah, you do that, right? You do adapt to the situation. We could not see the Brazil thing exactly like a copy paste, but then a bit of things that we need. Again, it was with the people, with the connector role, asking them where can Chewies help out.
So these these Chewies, they're attached to a health clinic.
Yes.
Okay.
Yes. So they're attached to the GP practice.
Yeah.
So one GP practice would have 3 of them or 4 of them.
Yeah.
And then in Westminster itself, there'll be 28 because there are 5 GP practices they work with.
Yeah.
So that's how hyper local it goes.
Mm-hmm.
And so does the GP practice pay the salary or?
Yes. Yeah. The GP practice find it very valuable, so they pay some part of the salary. There's National Association of Primary Care that pays salary and gets that fund. What I've recently come to know is that there may be other organizations that may be willing in to fill up the gap for their salaries. It's always challenging. I understand there's a bottleneck for funding, but I'm finding it.
And sorry, I'm interrogating you here.
Absolutely.
So just the picture you had, there was one lady who was wearing a uniform.
Yes, that's it.
Is she what sort of qualifications are they looking for when they hire people?
It's just the altruism that you want to do something for the society.
So they're not like here we have personal care assistants.
No. There's no specific background. We've got retired nurse being one of the Chewy because she just wanted to be in the community, interact with people, not be at home. And then she had this brilliant medical knowledge she could help people with.
Yeah.
There were some maternity champions or community champions who ended up being Chewies because they felt this role fits in well and resonates with them, being more universal. So we've got masters of public health student being a Chewy, just for the time being. Yeah, so it's very, very good. Yes, I had a question there.
I had a question and then it got erased by the conversation.
Welcome to the dementia.
Yeah. What's the staff retention like for the Chewies?
Very interesting.
That's like a bit of $1 million question, I know.
Yes. What I have seen is, I've seen the same 35 Chewies being there. There are a couple of them, they're not continuing right now because of their family conditions or anything. But most of them stay back. So retention rate is higher, but if you ask me the exact percentage, I won't be able to give you right now.
Yeah, interesting. Oh, wait, I remember what the other question was.
Yeah.
The evaluation of the program. Are you looking at the extent of the follow through from what the Chewy puts into like system 1 or whatever into like an actual the GP did something about that?
Yes, absolutely. So we are going first phase of evaluation with Chewy's narrative. What happened? How did they help someone? We've come across 12 brilliant case studies, and that is where they have helped start that conversation, got them the GP appointment, and got diagnosis within this 1 year. So we are going to evaluate that more. It is just that basic data or some data that we need from the GP practices needs ethics. We will be putting in if we need more concrete, but we understand this is more about 35 Chewies, and it was more of a pilot to see acceptability and feasibility of whether this has the potential. We go ahead and scale up to the other 200, and then maybe we can ask for a collective ethics on tell us the data points. So that way we would see, and Bianca was also giving her insights on the time to presentation at the GP practice to the diagnosis. That's what we can get through the narratives because they would have the dates. So
I think that would be really interesting.
Yes,
yeah,
absolutely. And we'll go pre and post. We'll see what happened before. Maybe randomly select some of the participants or the residents and then see the ones they have helped. And was there any difference? So there's a lot of opportunities to evaluate that on different levels. We'll explore.
Very cool. Thank you.
Thank you.
If there's no more questions online, I might. Any other questions in the room? No. I'm going to ask one last thing then,
please.
Which is theoretically, how would you see the role of these community health workers? Do you have a kind of theoretical framework informing?
Yes.
This research?
Yes. So we are working on the realist evaluation just to see if we can come up with the mechanism of what exactly happened. But at the same time, we can have our cognitive behavior framework, COB, and just see that framework, where it fits in, where they came, what was the behavior change, and what happened. So we've got a couple of frameworks that we can, when we do our evaluation part, we can build in. So we'll make it more, rigorous.
All right. No more questions, comments, nothing more online? Okay. I might, I guess, use this opportunity to encourage those in the room, on the virtual room, if you want to give a little virtual clap for Pallavi, and for us in the main room, we'll give you a little clap.
Thank you so much. Thank you for your time today. Thank you.
So thank you very much, Pallavi, for your time and for sharing this model with us. Thank you to Suri for hosting the event.
Yes, thank you.
The recording of the seminar will be available. We'll put it on the Mindcare Collective channel on LinkedIn as well. So if you want to share it around, you're most welcome to. And with that, we will close a little bit early and give you all back 5 minutes in your diary. Thank you so much, Pallavi, and have a nice afternoon, everyone.
Thank you so much. Thank you for this opportunity and for having me here. Thank you.
Wonderful.